I know this topic is like, you are like, we are not MBBS students and why are you making us teach this topic? I agree with you because in every MBBS, once you get into the clinical branch with the first is the case history, your presentation, every teacher, like whether it's medicine, surgery, ortho, they expect from you. But as you know, we all learn everything new, every day new things. So today also, if you want to learn, if Kapoor sir is presenting, I will learn new things, how to present a case. So this is like for being joined as an MD or a DM student. So as ma'am also said, there are different categories on which you have to do the case presentation. First and foremost, like when we are sitting in the OPD and when our resident comes to us, okay, ma'am, this is the case and this is the diagnosis which I have made. It's totally different when you're giving a ward patient round. Plus, if you're doing for a case presentation in your department, that is your morning classes, when you have a case presentation, at that time you have to present a case in a different format. If you have an interdepartmental meeting, like suppose cardio-nuclear meet or a cardio-radiology meet, then it is totally different. And if you want to go to a mortality meeting, then you have to present differently. So in outpatient, why we think that the case presentation is important. There is a very beautiful line from Hutchison. If you see the first page of Hutchison says, making the diagnosis, establish the clinical features by history taking and physical examination and investigation. That is our clinical database. Then you have to interpret this database, telling it what is the pathophysiology. But despite proliferation of modern diagnostic tests, irrespective of how many tests you have, still our history taking and physical examination remain the essential skills. So your DD, your diagnosis should be made after the clinical history and physical examination. You should not depend, okay, let me see the MRI report, let me see his, they will help you in the diagnosis. At least the differential diagnosis should be made once you have seen the case. I will not go into the art of history taking in Hutchison. These are the points you have to say. I know you all are well versed with it, which will not go into detail. And what are the physical examination which you have to do in these cases? You all are well aware there are general examination and a systematic examination. But how to give a patient case presentation round in outpatient or you're a ward round? Generally, whenever you go for an outpatient or a ward round, oral case presentation should be brief and it should be limited within 5 to 10 minutes. You should not tell an OPD patient over 30 minutes with no consultant, no colleague will expect you to give a history for 30 minutes. A 5 minutes short history is essential, or is it? It should be suffice to make the diagnosis. So how to make it 5 to 10 minutes? That is the skill which you have to learn in your MD and DM time. Because in MBBS, we all go, okay, for half an hour session, 45-minute session will be there. But during outpatient ward round, how to make it that has to be sufficed. So when you are presenting the case in the ward or the OPD, generally 3 points you should always discuss. What 3 points should be there? Only relevant, important patient information and clinical data should be said. Like from a cardiology point of view, I just want, okay, what are the symptoms? I don't want, okay, it was a full umbilical congenital heart disease, a CAD, suppose patient, I'm not keen, it was a full-term normal vaginal delivery or not, or this patient had a pregnancy at a delivery at home or delivery at the hospital setup. I know it's a 50-year-old male with coronary artery disease. This will not change my management or the diagnosis in this case. So only important patient information and the clinical data of that patient to be described. Out of that, when you are given the history, you have to make, it's very, looks very, bad also, it looks a bit good, that you are just telling, okay, this patient came with breathlessness, this patient came with chest pain. Okay, what is the DD? Is it a cardiac chest pain or a non-cardiac chest pain? So whenever you tell the history, you have to infer, you have to identify that what type of chest pain we are going to analyze. Suppose it's abdominal pain, you should at least have the DD. Okay, this is the pain which is causing you to appendicitis, or it is a colic pain. That part you have to give it the diagnosis. Because if you just say, it came with abdominal pain, so then you can't infer what it is. So always when you tell the chest analysis and identify issue, it will be producing a list and generally termed as a problem list. Then third thing which is expected from, especially during the ward rounds in your is how to managing these cases by developing a therapeutic plan. Like suppose you are on the round, I will tell mostly of the cardiac because frankly speaking during my MD days I have literally forward and about what the end of that would be. So if a patient of cardiac, say it's breathlessness or it is in hypotension, so I want from you that it is a cardiogenic shock, it is a septic shock, it is a hypovolumic shock, and what is the therapeutic plan which you are planning in this case. You should not always say, ma'am, this patient is in hypotension, that is it. You have to tell it's a hypotension due to what cause and what plan you are going in these cases. So whenever you go for a history, this is the SNAP method, which was very beautifully described. This you can keep this method when you're going for a long case presentation also, and if you want to go for your outpatient or a ward round also. What is SNAP's method? It is a mnemonic which have been made. S means summarize. Summarize means you should tell your summarize in only 3, 4, maybe 1 or 2 lines, not more than that. Suppose a cardiac patient, if suppose this, it should be only a 25-year-old female exertional breathlessness for 3 years at present class 3 with episodic palpitation. Your summary should not be this patient is married with occupation of this, with having this, and not presenting with breathlessness, and then this was having with climbing stairs, now it is climbing this. This is for history of present illness. When you're going for a ward round or going for OPD thing, you should summarize your case that this have been in a 1 or 2 lines. That is expected from you, and always give relevant information. Never forget, if possible, give relevant negative data also, that in the form of, okay, there is no history of pedal edema, there is no history of syncope in this case, but don't start saying there is no history of abdominal pain, don't start saying there is no history of seizure disorder, when you are not suspecting in this case. So always it should be relevant information. After summarizing, narrow the differential. What is N? That means you have to say that, okay, this is the diagnosis, symptoms which are there. Now, what is the differential which want to make? So narrowing the differential, always the consultant, while you're presenting a case presentation also, he will always ask you, okay, what are the diseases you have made? You know, this is a breathlessness. You are suspecting this is a pulmonary venous hypertension. I'm sorry if I'm talking more about cardiology, but this is a general thing which we are going. So if it is breathlessness, it has to be a valvular heart disease, it could be a cardiomyopathy. If it is abdominal pain, you have to make a DD if it is a cholecystitis pain or appendicitis pain or it is a colic pain. So DD should always be in your, when you are presenting the case, because otherwise just presenting your symptoms will not help you in assessing or whatever at the round also consultant or your colleagues will not be able to infer what are you trying to say. So always make the differential diagnosis. Third is analyze. Analyze means why you suspected this case, why you suspected this differential diagnosis. Then the third question a consultant or a colleague was asked, why you made this DD? You can say that this patient, suppose I say it's a patient of valvular heart disease, that means for me, I am finding a murmur in this case. On physical examination, I am finding this. Or if you see epidemiologically, this is a young female with a presentation with your breathlessness, and in our setup, it is mostly rheumatic heart disease. So you have to tell, okay, why you made this diagnosis, especially when you're going for a case presentations. These are the DDs, and then why you said this way has to be specified in your cases. Next is your probe. Always when you are going for presentations, expect this thing that the other person who is sitting on the other side of the table, he will always ask what is the unusual finding which goes against your diagnosis. You have to keep in your mind, okay, these are the things I might be asked that this I'm finding, I'm not finding in my case. So that person can definitely ask, okay, this is not the finding, why you made the diagnosis. Or suppose this finding is there and why you made this diagnosis. So always discuss the unusual findings. Suppose you're not able to understand that, okay, there is some bilateral clips, but these clips are coarse or they are fine clips. So you have to have the diagnosis, okay, this is the unusual finding. Patient is not having any orthopnea, still is having a very coarse clip. There may be some pulmonological cause also. So don't keep yourself, your tubular vision that this has to be a cardiac only. Next, after the presentation, you will be asked, okay, what the management of the patient is. That means what are the investigation which you are going to see get it done in this patient, and how will you manage this patient. That means, should you go for never tell the list of investigations, always tell the relevant investigations. Okay, I want to do an ECG in this patient, or I want to do an echocardiography in this patient, and what medical management I want to do. Suppose it's a breathlessness, you're suspecting a cardiac cause, you say, I will give a diuretic in this patient. Suppose it's breathlessness due to lung cause, you will say, okay, I will just have to nebulize in this patient. Whether I need oxygen therapy, non-oxygen, no oxygen, you have to tell, okay, this is the saturation of this patient. Then, followed by what will be the long-term plan in your case. Go for a percutaneous or a surgical option that has to be discussed. And fifth and most important, select issue. Whenever you do a case presentation, always go back and read about that disease, whatever the diagnosis you have made. That means, suppose you have made a diagnosis of rheumatic heart disease, always try to go back and read that part of the rheumatic heart disease. Suppose you have made the diagnosis of congenital hypothyroidism, or you have made the diagnosis of your fetal tachycardia, go back and read that part. Okay, what is the patient problem? Because next time when you're going for a case presentation, you're going to see the same case in your career, so that you will be able to memorize the things that, okay, these are the things which I have to look for. These are the DDs which I have to see. These are the DDs how to go for it. So this is the thing when you go for a outpatient or a ward round, give a short history. And if you are going for a case presentation in your morning classes, give a elaborate history. But the points will be definitely discussed whenever the consultant or the colleague will be there with you. These are the snap analysis which you have to keep in your mind. Okay, this is the thing which I have to present in a case. What about the interdepartmental meeting? Like you have to go for a cardioradiology meet, you will be having radiology, endoradiology, neuroradiology meet. So interdepartmental meeting, it changes a little bit. Why so? Because now you have colleagues which are not from your field. So you cannot tell the words, you cannot use the words which are, only limited to your field. Like if I started saying, okay, we did a PCI in this case, I'm 100% sure non-cardiac branches people will say, what is PCI? So never use that jargons or the small form in which, the colleague will not be able to understand. So the interdepartmental meeting, you should have a different protocol. What is that? First and foremost, introduction, that why you selected this case, why you want that this case to be discussed in your interdepartmental like cardioradiology or nuclear radiology meet. Either there is some diagnostic dilemma in your case, like suppose you find some lesion, you are not able to explain it by his symptoms and your investigations are not correlating whatever you are clinically seeing that patient, then you might want to discuss this case. And second is if it's a rare finding. That means this is a very rare disease which you have never seen in your, and you want to discuss with your radiology or a neurology colleague that what is there in this case. So always don't use jargons which are just limited to your field, and don't make small forms in your which you are not able to understand. In this case, you're going for a slide presentation mostly. These are not the oral presentation. Whenever we go for an interdepartmental meeting in your department, always just make a relevant history present and past. Only 1 or 2 slides. Not more than 2 slides are needed for a relevant history in physical examination. Because you don't want everything from starting, okay, this having symptoms for 10 years, then after 2 years it became class 3, then after 3 years became class 4. You don't need that type of thing, because your other colleague from other department is not interested. He just wants to be interested, okay, it's pain with breathlessness, he has chest pain. So that is the only thing he or she wants from you. So only do for a relevant history, present and past, and a relevant examination features, which you think that within 2 slides you can explain. When you are presenting an interdepartmental meeting, make presentations little interesting. I'm pretty sure Kapoor sir, the next talk of podium presentation, he will give you very beautiful animations in his slide, which is missing in my slide. So always try to put photographs and relevant investigation and try to give it an animation so that the other person can grasp it very easily that what you are going to tell in your case. 4th slide should be provide differential diagnosis in your case. Because once you are discussing with the interdepartment thing, why you want this diagnosis, why you want this case to be discussed, always mention that this is the DD I want to show. I'm getting confused between this diagnosis and this diagnosis, because the other person who is sitting across the table, he should understand why this case you have considered. Always provide follow-up using flow charts or tables. Don't try to just cut, paste, and copy your time. Okay, hemoglobin 10.1. Next day, hemoglobin 9.3. This will not create a clear picture of what you want to convey to your colleagues. Or make it a flow chart or a table. Okay, this is the thing this on first day it happened like this, second day was this investigation, third day was this investigation. Just don't write it or type it in your presentation. And always mention your final diagnosis and treatment, what you thought that this was the diagnosis and this was the treatment which I advise in this patient in my case. After making the differential diagnosis and treatment, if you are going for interdepartmental meetings, keep 2 or 3 slides for the review of literature, because the other person from the other department, they should understand what the importance of this disease is, which you want to discuss. Like suppose in our case, if a patient of ventricular tachycardia comes and you want to put a cardioradiology meet, I know I have to keep the cardiomyopathy as a DD. Suppose this comes out to be sarcoidosis and we have got a PET and CT done. I should have a 2 slides of review of literature that these are the points, these are the things which I'm finding in my case, which is similar what it was reported earlier. Give relevant case reports in your slides so that they can understand what is the disease which we are talking about. And give few studies from India and what are the guideline recommendations. Like suppose I made the diagnosis of this case, what does the guideline say that how to manage this case in these cases? So this is the basic interdepartmental meeting when you're going for presentation. What about the mortality meeting? I'm pretty sure no department, no resident wants their case to be selected in the mortality meeting as a CGR, because we all know, okay, my case, we will just be scrutinized. We will be like, we will be kept like this. I kept in a katghara that, okay, why this happened in your case? Why this was not done? So your presentation should be more crisp and more refined when you're going for mortality meetings, because interdepartment and intra-department meetings, the other person can understand, okay, this thing happened because we know that this was bad prognosis in this patient, that's why it happened. But in intermortality meeting, there are colleagues from different fields. So they should have a clear picture of how sick was the patient and how poor their prognosis was, and you have to explain in that format. So mortality meeting presentation becomes too important. So if you want to see the mortality meeting presentation, it is not something like which we have to be just to make fun of other department or have to scrutinize. We should always take it in a healthy format. Okay, if a case has been selected in a mortality meeting, we should just present in a format that it's for a discussion. It is not for we are going the blame game should never be there in between the different departments or interdepartment consultations that we said this thing, the other department didn't do, so it's not my fault. So these are basically, if you see, it's a workplace learning from each of us. That suppose any patient admitted in neurology and develop some cardiac issues. So if consultation is done, it should not be a blame game thing. It's a lesson learning which we are going through each other. It is basically why we want to do a mortality meeting in our institute. Is basically we are just checking what is the quality of standard we are providing to our patient. That means it's a measure of quality of care both for the patients and the providers. The goal, discuss errors and adverse events. We all are human beings. We are not machines, and we know we have errors. When suppose we are tired, we have seen the patient and we didn't recognize that this patient is having poor prognosis, he is in hypotension, we might make error. So we have to accept that there are errors which occurs at our level. And adverse events in an open manner. So drug interactions, your different contraindications which were there, and despite that drug was given, or suppose the creatinine was 3 and despite that a contrast CT was done. These are the adverse events and errors which can happen at our point. So it should be discussed in an open manner so that this happened this way, but it was necessary to get it done, otherwise we would have lost the patient. Then it is review case standards, that what is the care which we are providing at the emergency level, what are the care we are providing as the first point of contact, and what are the care that's providing as the follow-up of these patients have to be seen. And suppose in mortality meeting we find that there is some lacuna in our part, then you have to make changes if required. So that is the purpose for the mortality meeting. Same components, but in mortality meeting, obviously these patients are sick, which are coming to us. So there are different stages of management. First and foremost, we have an emergency department with us. So definitely there will be a triage that whether this patient should be coming to a ward and it should go into an ICU or it should go to a CCM department. Then what is the emergency treatment was given at the emergency department. After that, once you take the patient in your ward, you have to write the history and examination and lab investigation, which you did in your case. And what are the differential diagnosis? Plus this patient, if it has a long hospital stay, give it monitoring treatment and supportive care which was provided, and what's the outcome. But in this the things, but a mortality presentation should have something different which are compared to your interdisciplinary departmental meetings. Headings and subheadings will be the same as interdepartmental meeting, which I discussed. Don't use jargons or don't use short forms, which the other department cannot understand. Sequence of events should be clearly highlighted. This becomes very important at what time the patient develops hypotension or what time the patient develops fever. That will definitely change your treatment strategy or your treatment outcome. Don't copy paste. You know what looks bad, you just take the picture of the treatment chart and you just copy it on there. Okay, this treatment was given. That should not be the format. One, it is not able to read from that what you have pasted there. Second, it doesn't show that you have not put any effort in just writing down what are the treatment chart you are given. So don't make a cut copy paste when you're going for a mortality meeting presentation. Investigation in clinical course, don't just type it that, okay, this is the day, this thing like that. Try to make a flow chart or a table. In a flow chart, you can say, okay, this was first day, her blood pressure was this, second day, her blood pressure was this. So it will give a more pictorial representation. It will be more comprehensible when you go for a flow chart and presentation. Then discuss the course of events and what treatment was offered and what was the terminal event. Don't write cardiac arrest. We all know everybody will be dying with cardiorespiratory arrest only. That is the terminal event. But what happened before that terminal event? Whether it was your asystole, whether the patient developed stroke, what is the cause of the terminal? There are the cardiorespiratory arrest as a terminal event in your cases. So these are the few next slides. Like suppose you want to present the clinical course. You should present the clinical course in this tabular format. Okay, on 5th, this patient got admitted. This was a blood pressure, saturation, and pulse rate. On 4th day, patient was sick. He got intubated. Marked as there. On 5th day, the patient had a inotropic support, and there was some VT or VA which happened. And this was the terminal event. A patient became hypotensive. So this gives you a clear picture that this patient was sick from 7th of when it came. So what happened on 7th with this blood pressure fell from 106 to 96? Why patient was intubated? Why it's got increased inotropic support? So this gives a little comprehensive pictorial presentation that the other department colleagues can also understand. No, this patient was sick. This patient stayed for 3 days, and this patient on 3rd day had an event which led to this all that catastrophe. So this another writing, okay, first day pulse was this, the other department people will not able to comprehend. Like investigation charting, try to make it a tabular format. Don't copy, take a picture from your HIS and paste it there. It will never be able to comprehend, okay, what is the basically asked. So just make it a tabular format investigation that, okay, these are the investigation which this was the course of the patient's prognosis. Terminal event. If you can get a pictorial terminal event, okay, the patient was having sinus rhythm, suddenly developed PT. So we know the terminal event which happened was a ventricular tachycardia. So if you can get that picture, I know it's very difficult sometimes to get a terminal event clarity. But if you can get any patient, give a pictorial representation that this is the terminal event which happened. So the other person sitting will not have any question, okay, what was the terminal event, why did the patient expire? So your questioning will also decrease when you go make these presentations just like a pictorial or with clear presentation. Other important components, sometimes we put mortality cases when they are very clinical case, which are rare case phenomena, or have been having adverse event reviews, or there are some reviews of near misses. Adverse event reviews, sometimes like in a mortality, how do we select these mortality meeting files? It's not like that only case some department is being done. Basically, suppose any adverse event happens to any drug, and this shows that this patient it's a rare phenomena. That time we try to select that case in a mortality. And if suppose there are some near misses, like this patient came and deteriorated, and it was death could have been prevented, or they have to be done, these cases are selected. Notes and case presentation. This was whatever you can do, what you should not do in your case presentation. That means sequence events is not followed. Like you present your case history or you can present your slides. You start with day 1 and you skip over to day 4 and again come back to day 2. Never do that, because that will not create a clear picture who is sitting. You might be clear in your mind that, okay, I told everything, why that person is not able to understand. But if you're not given a sequence of events, the other person will never comprehend what are you trying to say. Never write too much on a slide. Never write 5, 6 lines on the, because if you start reading, the other person will also start reading and they will never will comprehend what you want to say. So always make a bullet points and just make 4, 5 bullet points, which the other person you can explain in your time. Poor time management, never too long. Suppose you're giving a 30 minutes time, finish it within 28 minutes. That will give a good impression. Okay, I have finished my talk this, because you need time for interaction. Because other department who have come here, who are sitting, they want to ask questions from you, that why this patient, suppose why this happened, because they might not be aware what do you mean by ventricular tachycardia and why not cardiogenic shock or defib was given in this case, cardiac or diverted. They want to interact with you. So they always give time for interaction. And review of literature not relevant. Don't give a review of literature. Whenever you present a mortality meeting or an interdepartmental, don't give review of literature of 5, 6 slides and 5, 6 pages. Give relevant point, give relevant case studies, give relevant case histories in these cases. So this is the basic case presentation in which you have to follow it for next 3 years. Thank you. Any questions which you want to ask? या तो कुछ समझ नहीं आया, सबसे समझ आ गया. हाँ.
Suppose in any case present, the optimal slide length is how many slides?
So what I showed in interdepartmental slides, 2 slides for case history, 1 slide for your present. Yeah. So 2 slides for relevant history, 1 or 2 slides for investigation, 1 slide for DD, and 1 slide if there is some flow chart or treatment you want to show, and 1 slide for final diagnosis. So total 7 to 8 slides should be the more than enough when you're going for a mortality meeting or an interdepartmental case presentation. Because nobody wants to hear too much cardiology or too much nephrology or too much neurology. That's a fact, because other departments will not be able to understand, they will not be able to focus there.